The subcommittee will come to order, and welcome, Dr. Frieden. And good afternoon. Today's hearing will examine a deadly phenomenon involving both natural and man-made elements, diseases that are resistant to most or all available methods of treatment. While this is a growing problem of increasing concern throughout the world, the subcommittee will be focusing today on the impact of such diseases known as superbugs in developing countries and the challenge to preventing and treating these diseases in this part of the world. There is a family of germs that occur normally in everyone's digestive system. They can cause infections when they get into the bladder, blood, or other areas where they don't belong. That is the natural part of this growing problem. Gut flora are absolutely essential for health and an effectively functioning immune response, and the increasing use of things like probiotics is testimony to the fact that more and more people are understanding that. There are about 100 trillion microorganisms in our digestive systems, 10 times the number of cells in our bodies. Most of them help break down the foods that we eat. They help us with our immune systems. Those that are not helpful usually can be treated with existing medicines such as antibiotics. The man-made part is that antibiotics have been increasingly used to treat naturally occurring germs, but many of them have become resistant to such treatment. These so-called superbugs pose a threat because of overuse or misuse of antibiotics, but they also pose a threat because of what some call a drug discovery void, in which there has been insufficient research and development of new medicines to treat emerging mutating infections. This situation recently has become much more serious. In the last 10 years, these drug-resistant diseases have been identified in patients in more than 200 hospitals in 42 states in this country. Over that period, their prevalence rate has increased from 1% of patients to some 4% for those in short-term care, but for patients in long-term care facilities, the rate is as high as 18%. Half of all patients who contract these diseases do not survive. MRSA, one of the better known of these superbugs, now kills as many as 19,000 Americans each year, and a similar number in Europe. That is higher than the annual rate of deaths from HIV and AIDS. Last year, the World Health Organization identified strains of gonorrhea and tuberculosis that are currently completely untreatable, as well as a new wave of what might be called superbugs when the mutation known as NDMI. These frightening new strains were first seen in India, but they have now spread worldwide. The spread of the H7N9 bird flu in China is also causing considerable concern, with more than 100 confirmed cases and 22 deaths reported thus far. According to the AFP, WHO said yesterday that there is still no evidence that H7N9 was spreading in a sustained way between people in China. And I know Dr. Frieden will speak to that because we are working with the Chinese on that issue. According to WHO, artemisinin, when used in combination with other drugs, is now considered the world's best treatment against malaria. But malarial parasites resistant to the drug have emerged in western Cambodia, along the border in Thailand, as well in parts of Burma and in Vietnam. In the developed world, we pride ourselves on having top-flight medical care widely available to patients. If we lose half of all patients who contract these drug-resistant diseases, what about patients in the developing world where statistics are often scarce and effective medical care can even be scarcer? Using accepted protocols for treating these diseases, their rate of infection can be curbed. In Israel, infection rates in all 27 of its hospitals fell by more than 70% in 1 year with a coordinated prevention program. By following accepted protocols for handling these diseases, the Colorado Department of Public Health and Environment and the Florida Department of Health both have stopped outbreaks of these drug-resistant diseases in recent years. But then again, what about hospitals in developing countries? For example, the brain drain has sent trained medical personnel in Africa in search of better working conditions and pay in the developed world. The lack of equipment and supplies that partly led to this brain drain would facilitate the rapid spread of drug-resistant diseases in these countries. What would be simple interventions, including removing temporary medical devices such as catheters or ventilators from patients as soon as possible, is less likely under current conditions in developing world hospitals. Adding to this problem is the presence of expired and counterfeit drugs. Patients whose lives, I should say, could be saved may not be because of inadequate medical care. Unfortunately, because so many countries do not maintain and report statistics on medical issues, we have little idea how serious the situation is today in many developing countries in Africa and elsewhere around the world. In our interconnected world, that means that infected people in the developing and developed countries pose a mutual threat. Last month, a Nepalese man who was detained at the Texas border while trying to make an illegal crossing from Mexico. Officials found that he was infected with an extensively drug-resistant strain of tuberculosis and had carried this potentially deadly airborne disease through some 13 countries over 3 months, from his home of Nepal through South Asia, Brazil, Mexico, and finally into the United States. Who can say how many people he infected during this long journey? Conversely, 6 years ago, an American infected with multi-drug-resistant tuberculosis traveled from our country to France, Greece, and Italy before returning through the Czech Republic and Canada. Upon his return to the United States, he became the first person subjected to a Centers for Disease Control and Prevention isolation order since 1963. Clearly, both developed and developing nations must work together to prevent and treat these diseases and find a way to implement the new strategies in an era of constrained budgets and loosening control of authority in far too many countries. However, the administration's proposed budget for 2014 does call for a 19% cut in tuberculosis programming, and hopefully we might get some answers today and again on Thursday from Dr. Shah. Today's witness, a very accomplished doctor, heads an agency that is charged with examining the elements of disease and helping to develop the strategies for addressing the threats they pose, not just to Americans, but to all mankind. We look forward to hearing from Dr. Frieden, and exploring with him the means by which the U.S. government is working with developing countries to counter global threats. I'd like to yield to Ms. Mass.